So detrusor muscle, when that muscle contracts, it voids the bladder. Okay. Contracts to void bladder. So in smooth muscle, it's under autonomic control. We'll talk about that. You know, the base of the bladder is called the bladder trigone. It's, I call it the water slide. It's shaped like a triangle because it has 3 points. Point here, and the third point there. Now these 2 points are the ureteric orifices. The ureters, they come and they empty into the bladder at the base of the bladder. Ureteric orifice. And the ureters, they kind of pierce the bladder wall at an oblique angle. So if this is like the bladder wall, it's like the ureters, when they pierce, they kind of like pierce at an oblique angle to empty into the bladder. That way, when there's an angle, when the bladder fills, it'll pinch off the orifice so you don't backwash urine up the ureter. Okay, because if it entered straight, no angle, the bladder wall stretches, it wouldn't really close it off. It might open it up. Okay, so this is preferred. Check. That's how it happens. It enters at an oblique angle. So as the bladder fills with urine, you shut the orifice, okay? So those are the 2 ureteric orifices, 1, 2. The third point of what's called the bladder trigone, this triangle, which describes basically the base of the bladder from the inside. The third point is an opening from the internal urethral sphincter. So I'm going to draw a little sphincter right around here. It's like the detrusor muscle, it lines the whole bladder wall. Smooth muscle. But as those smooth muscle fibers approach this orifice here, it becomes the internal urethral sphincter. So it's all smooth muscle. Now there's one sphincter that's voluntary muscle. It's the external urethral sphincter. And it's contained within the UG diaphragm. I don't know if you remember studying the deep transverse perineal, but within that was a sphincter. So, I don't know, I'll put like a, put it like that. UG diaphragm. Now, the external sphincter is voluntary muscle, okay? It's skeletal muscle. That's the one we can, with conscious thought, hold it in if you really feel the urge to go. So the whole point of the urinary bladder is to store the urine. So urine enters at the ureteric orifices, and because it's at the base of the bladder fills bottom up. which is good. If it filled from the top, you'd have all these like raindrops falling down inside the bladder. So it fills like bottom up. Well, imagine like there's, you know, lots of urine in there. So what happens is as you fill, you start to feel the urge to go at around 150 ml. You feel with afferent nerves, which we'll talk about. Around 150 to 200 ml, something like that. The full capacity of the bladder normally is around 500 to 800 ml. That's like, you really gotta go. Okay, just keep filling that thing up. The full bladder. What happens is, as you fill, you're stretching the bladder wall, and there are these afferent volleys, you know, telling your brain, you gotta go. Void the bladder. Call them afferent volleys. Send it to the brain. It increases the urge to go. Since we just had a break, you probably voided your bladder and you're probably not feeling that now. But that's what's going on. And I want to go over that in more detail. But first, let's look at the female urethral tube. So, because remember, this is holding it, but when you do want to go, you want to exit urethra. So here's what I want to ask you. I have three structures here: detrusor, internal, external sphincter. If you want to hold it in, here's what you have to do. You want to inhibit detrusor, and you want to stimulate and contract both sphincters. That helps you hold it in. What books usually say storage reflexes. Inhibit the muscle of the bladder. Contract, contract. When sphincters contract, they keep the urethra tight. They keep it shut so it doesn't dribble out. Okay. Therefore, let me ask you the opposite question. When you want to void your bladder, what do you got to do? Well, I guess it's the opposite. If you void your bladder, you contract, you stimulate, you don't inhibit, you stimulate the detrusor so it contracts. And you want to let these sphincters relax. So stimulate, relax, relax. So I want to be sure that that's clear before I move on. One is to hold it in, one is to basically void. And when you void and relax the sphincters, a little urine reaches the proximal aspect of the urethra, and it basically tells the brain, voiding is imminent, you're gonna go. Okay. The female urethra is much shorter, a couple of inches, but same equipment is still there in terms of the bladder and the urethra. You have detrusor muscle, you have the bladder trigone, two ureteric orifices, one orifice for the internal sphincter. Remember, the internal urethral sphincter is just the detrusor muscle fibers. As you get close, it kind of forms the internal sphincter. The external sphincter is voluntary muscle within the UG diaphragm. Okay, so all the same things, male and female. There's no gender differences there except for the length of the urethra. Now, the nerves that control these reflexes you got to know them all. You got to know the afferents and the efferents. And because it's the efferent, you got to know both kinds of nervous systems, somatic, autonomic. And because it's autonomic, you got to know sympathetic, parasympathetic. So that makes it kind of like 3 in the efferent division. All right, let's go through that. So the sensory or afferent division is given by the pelvic nerves. So that's the name of the nerves for this reflex. Pelvic and end nerves. And let's remember, in the sensory division, the structure of the cell, it has that pseudo-unipolar design. Kind of like that. Sensory nerves, pelvic nerves. They help you feel that your bladder is full, and they participate in these reflexes. All right, for the efferent division, the motor division, the somatic nerve, you got to know, is pudendal. It will innervate the external sphincter. Okay. External urethral sphincter. And when sphincters are stimulated, they contract. The other efferent division is for the autonomic nervous system. So ANS. Okay, the sympathetic division is for your storage reflexes. It helps you hold it in. That's the sympathetic response. Hold it in. And the nerves from the sympathetic division that help do that are called the hypogastric nerves. They innervate two things: the detrusor and the internal urethral sphincter. Internal urethral sphincter. The parasympathetic division uses the pelvic splanchnic nerves. Those nerves innervate the same thing. However, they do the opposite. I said sympathetic helps you hold it in. The parasympathetic nerves help you void the bladder. So I'll say for sympathetic, hold it in. If that's the case, you do the reverse thinking. So you know what it accomplishes. Therefore, how does it affect these two things? Well, if you want to hold it in, you inhibit the detrusor, stimulate the sphincter. That helps you hold it in. And do the reverse thinking. Okay, well, if the parasympathetic helps you void, you would do the inverse. You want to inhibit the inhibitory. You want to contract detrusor. You want to stimulate the detrusor to contract. That helps you avoid the bladder. And at the same time, you have to relax this sphincter. And don't you have another sphincter to relax? Yeah, well, there's the external sphincter. You gotta relax that one too. So here's a figure that can help you with those reflexes here. This is has since been removed from your book, but I still use it, so I'm going to give you access to this figure from previous editions. It maps it out very well. It has all the nerves you just outlined, and so let's take a look at it. On the left, hold it in, storage reflexes. On the right, void. And they show you the central nervous system, and the bladder, and everything else. They show you part of the medulla, the pons, that's where these centers are. That's how the brain can help, it's part of the midbrain. They show you a part of the thoracic or lumbar spine, because that's the sympathetic division. And then they show you sacral spinal cord, because that's the parasympathetic division, so it's all there. And so what I would note from this first picture here to help you hold it in, let me write it down for you. One thing is called the somatic loop. Hold it in. Storage reflexes. One, I would study somatic loop. The somatic loop is a reflex to keep urine in your bladder so it doesn't dribble out. So you have to look at the afferent nerve. It's colored blue. The pelvic nerves are shown here. You see that little pseudo-unipolar design? So the bladder is filling. And you start to feel this at about 200 ml. And it sends one signal up there, but that's not the one I want to talk about. We call it a somatic loop because it uses pudendal nerve. Here's the loop right there. So it goes afferent in, efferent right back out. Okay, so the loop is the pelvic nerve has a direct input on the pudendal nerve to contract the external sphincter. That's what I want you to write. So the loop is pelvic nerve directly to pudendal, directly to the external sphincter. Put a plus sign for stimulate. When you contract that sphincter, you hold it in. So that's reflexively happening as your bladder begins to fill. 100, 200, maybe you're on a long bus ride and you can't get off and you're really starting to worry. And it's like 300, 400, 500. Now it's like you're trying to hold it in. This loop can be influenced by the brain. You trying to hold it in, crossing your legs, all that stuff. Well, what happens is, from the brain, if you look at the picture, it's called the pontine storage center. Call it brain. It sends an efferent down to directly reinforce and stimulate pudendal. Because that's the only thing you can affect with conscious thought, the external sphincter. So conscious input from brain. That helps reinforce the loop. Okay. Now the other thing about the afferent nerve, it stimulates the hypogastric nerve. So follow that. So we're going to follow this one here. This afferent signal is going to go up to the sympathetic division. It's going to stimulate the sympathetic fibers, and it does two things. One, inhibit detrusor, stimulate the internal sphincter. So I guess call this number 1, somatic loop. Number 2, hypogastric, I'll say stimulate hypogastric nerves. They do two things. They inhibit detrusor, stimulate the internal urethral sphincter. Then the long bus ride's over, you get off, you run to the bathroom, and you got a full bladder. This is what happens. Let's see here. So where do you start? Okay, well, it's a conscious effort. Usually you stand there, you contract your muscles a little bit to increase the abdominal pressure. That helps put pressure on the bladder. And once a little bit of urine reaches the proximal part of the urethra, it sends a signal to the brain to like, okay, you're gonna go. And here are the efferent signals you need to keep track of. Voiding reflexes. You've got the pontine micturition center. Follow the parasympathetic efferents. I'm going to outline 3 things that this teaches us about those reflexes. The first thing is you inhibit hypogastric. That's shown right here. This first thing coming down, the parasympathetic fibers, boom, right there. Negative sign. Inhibit the hypogastric. Because what did the hypogastric do? It inhibited detrusor. So it's like you're inhibiting the inhibitory. Number 1. Inhibit hypogastric nerves. Okay, so you got to turn that guy off. And the other things you do, number 2, there are parasympathetic efferents in the pelvic splanchnic nerves. These nerves, they stimulate the detrusor and inhibit or relax the internal sphincter. Write that down. Pelvic splanchnic nerves, they do a couple of things. Stimulate the detrusor and inhibit or relax internal sphincter. The third thing is the parasympathetic efferents inhibit pudendal. That's going to relax the external sphincter. Inhibit pudendal nerve, relax the external sphincter, and that'll help you go. So, I mean, I think what's hard about that is trying to remember all the names of the nerves. Hypogastric, pelvic splanchnic, what does what. Spend some time with that, it makes perfect sense. Hold it in or void your bladder. It's pretty basic for the bladder reflexes. I'm going to shift gears. Last topic of your A&P career is called sleuthing, using blood values to determine the cause of acidosis, alkalosis. So we're going to get back to stuff we talked about before the break. acid-base balance, and it's going to tie in the respiratory system. And I got to reduce it down to fit in one part of a lecture, so I'm going to keep it to like these 8 different diagnoses. There's more, but we'll keep it to these 8. Using blood values to determine causes of metabolic acidosis or alkalosis. To determine causes of either acidosis / alkalosis. You will be given multiple problems on your exam on Thursday, but well, I won't do 8 problems, but I'll do multiple. The question becomes, which of the 8 will I give you? I got to teach all of them. You don't know what you're going to get. You have a patient, you don't know what you're going to get. And the basic idea of using blood values is there's just a few things I'd like to refresh your memories on. Just a few. First thing, the normal value of pH for the blood has a range of 7.35 to 7.45. That would commit these normal values to memory. That's what you're trying to maintain. If you get less than 7.35, that's acidosis. If you get greater than 7.45, that's alkalosis. So less than that, acidosis. Greater than that, alkalosis. The different blood values you can measure and assess are, well, one is PCO2. If the alkalosis or acidosis is a respiratory cause, look at the partial pressure CO2 in the blood. For a respiratory cause, we'll look at PCO2. The normal range should be 35 to 45 millimeters of mercury. That's the normal range. Oh, that's easy to remember because the normal pH range is 7.35 to 7.45. That's a happy coincidence. So anyways, the reason why we look at CO2, CO2 can acidify the blood, if you remember this equation. CO2, you hydrate with water. You get a carbonic acid, which when it dissociates, you get an acid. So that's why CO2, if the levels are high, you push the equation this way, you get acid. So PCO2, if it's high, you can elevate to a level where it lowers the pH. So basically, let's say for example, patient comes in, blood work comes back, pH 7.2. And the PCO2 is 46. So I gave the normal range is 46, high, low, or normal. High, just a tick high, but it's high. That's why this is called a respiratory acidosis. Well, first of all, I went too fast. Is the pH, is that high or low? That's low. So, a high level of CO2, you're creating more acid in the blood, you're acidifying the blood, making pH low. Let's do the inverse. That comes back. Look at that first. Is that value high or low? pH 7.6. It's high. The value for PCO2, this same person, is 30. Okay, is that value high or low for PCO2? It's low. Does that make sense? This is the cause. It's a respiratory alkalosis because that value is low. So think about this equation now. If this is low on this side, it makes the reaction go to the left. So you take the acid out of the blood to get it to go this way to try to replenish the low CO2, I guess. So that makes that low value makes the pH higher. So I guess the easy rule to remember is, you know, like I say there, respiratory opposite. If it's a respiratory cause, the PCO2 value is high, making the pH low, they're opposite. Or the inverse is true, they're opposites. If the PCO2 value is low, it makes the pH high, respiratory opposite. Okay, you see what I did there? Let me think about that for a little bit. Let me do the next one. The other thing you can look at in a blood workup is what the kidney's doing. You measure the bicarb value. All right, let me get back. Okay, if it's a kidney thing, they call that metabolic acidosis alkalosis. Metabolic alkalosis, acidosis. Look at the bicarb value in the blood work. And the units are milliequivalents per liter. And the value, normal range, should be 22 to 26. 22 to 26 milliequivalents per liter. But anyways, that's the normal range. Now, this is the renal mechanism because the kidney regulates bicarb. So think renal when it's a metabolic cause. So let's say the blood work comes back 7.3, 0. Is that value high or low? That's low. So do we call low pH acidosis or alkalosis? It's a low form of acidosis. Let's pretend it's a metabolic cause, and let's look at the HCO3, the bicarb value. It's 20. Is that high or low? It's low. It's less than 22. So that's low. pH is low. So it's a metabolic cause. Low base, low pH. It's more acidic. Does that make sense? Low, low. Metabolic, equal. Right? Respiratory is opposite, metabolic is equal. If that's low and that's the cause, that's what's driving that low. Right. Well, let's do the inverse. 7.48. And 28. Okay, look at the pH first. Always look at that first. Is that value high or low? It's high, alkalosis. If it's a metabolic cause, look at the base. Is that level high or low? High. So if you have a lot of base, it drives the pH up, makes it more, drive it towards alkalosis. So high, high, that's when it's a metabolic cause, it's metabolic equal. High equals high, low equals low. If it's a respiratory cause, it's flip-flop, it's opposite. That high value causes a low pH and so forth. Now, both systems operate at the same time. And the challenge for you is to look at blood values, pH, PCO2, bicarb, and put it all together. Figure out which is the cause, respiratory or metabolic. And if you can determine the cause, is the other system compensating? Like, for example, if your kidneys are pooping out, okay, and it's a metabolic cause, is the respiratory system healthy enough to compensate? So let me take you through that. Now, before I erase this, are there any questions on the high-low, low-high thing? Well, the best way to get this down is to practice problems. Let's do that now. So your author calls this sleuthing, and I'm teaching right from the book. I'll give you a page number later if you want me to, but let me do some practice problems. The process taught in the book has students follow a stepwise procedure, basically just 3 or 4 steps. And to make it a fair fight, here are the values that I have to give you. I have to give you pH, so therefore memorize the normal values. That's normal. So I got to give you that. Okay. I got to give you the partial pressure of CO2. That's coming back in the blood work. So remember the normal range, 35 to 45. And the units are millimeters of mercury. It's the partial pressure in the blood. And I got to give you the bicarb value. The normal range is 22 to 26 milliequivalents per liter. Okay. So let's say, for example, let's call this 1, 2, 3, and save number 4 for a diagnosis. So what I'll give you is a patient comes in, here's the blood work. 6.9, 29, 19. And here's the procedure that Maria kind of teaches us to do, and I think it works pretty well. First thing, look at the pH. High or low? Low. So the first thing you can get right is you know it's acidosis. Then you want to determine the cause, if it's lungs or kidney, if it's respiratory or metabolic. And just look at the second value next, PCO2, to determine if it's a respiratory cause. Is that high or low? Low. Is that the cause? No, it's not the cause. It's outside the normal range, but it's not the cause. If it were the cause, it would be high. Right? Remember the rule, respiratory opposite? So all you say at this point in the diagnosis is respiratory is not the cause, and move on to number 3. Okay, so is that a value, high or low? It's low. So low base, low pH, that's the cause. Okay, the kidneys are pooping out. It's a metabolic acidosis. Write that down. The last thing to do is, the question to ask is, okay, it's a metabolic acidosis. The kidneys are having problems. Are the lungs helping? Are they compensating for this? Are they trying to help? So look at the value. If it's outside the normal range, the answer is yes, but think about, take it a step further. Why does that help? Low CO2. Remember what I said? If low CO2, you're trying to take acid out of the blood. this whole equation again, you're pushing it this way. So this is low. It's trying to help. You're breathing off as much CO2 as you can. Because if you do that, you're going to take the acid, which there's plenty of, and you're going to drive the equation this way. You're trying to take the acid out of the blood by breathing off the CO2. Okay? So what we say is you have metabolic acidosis with respiratory compensation. You can get more nuanced than that. You can say, oh, it's partial compensation. Oh, it's fully compensated. But we're not going to get to that level. Just at this level, we'll stay there. And if you got that, great. If you're not, the best way to learn is to keep doing more. Let's do another one. And the more you do, you'll be able to better identify where you're getting stuck. So just keep doing it. Let's do another one. Here are the values. 7.2, 36, 20. Let's just follow the same procedure. Look at the first value. Is that high or low? Low. So therefore, so far in your diagnosis, you say it's acidosis. Okay, look at number 2. Try to determine if it's a respiratory cause. Is this within the normal range? Yes. Yes, it is. 36 is within 35 to 45, right? So is it a respiratory cause? No. Move to number 3. Look at that value, high or low? Low. Low, low. It's a metabolic cause, low base, low pH. So, metabolic acidosis. The last question to ask yourself, okay, the kidneys are having a problem. Is the other system helping? No, they're not. It's within the normal range. If it were helping, it'd be low. So it's like, okay, well, whatever, that's the diagnosis. It's basically the same one except without respiratory compensation. Okay, do one more. 7.25, 48, 30. You go, talk about it with your neighbor, I'll check back in another minute.
If they're not opposite, like they're both low, then it's metabolic gas. On that one, yeah, because the kidneys are not within normal range, so they're trying to compensate. So it would be respiratory acidosis with renal compensation. Does that make sense? Yeah. Oh, okay, that's, I couldn't get it right. With your,
checking in. Let's check it out. 725, high or low? Again? I keep giving you low. Hey, it could be that on the test you're like, oh wait, you gave me two of the exact same ones. I could do that. You don't think, oh, it must be a different one because that was the last one. I could give you two of the exact same. This is also acidosis. Okay, let's determine the cause. Look at step 2. Is that value high or low? It's high. It's not the cause. Oh, it is the cause. I proved myself. So let's think about this. High CO2, it drives that equation that way. Yeah. What's my rule? Respiratory opposite. That's low. That's high. That's the cause. Respiratory acidosis. Okay, the last question to ask yourself is the other system compensating? Look at that value. Okay, that value is high, more base. That would compensate for acidosis. Lots of base compensate for that. So what you say is with renal compensation, because it's the kidney. Okay, one more. 7.32, 46, 25. I'll give you another minute. This time, don't talk it over. You go solo and see if you get it right. Pretend it's a test. I'll check back in just a minute. Okay, one more time. Repetition is the key here. Let's see, I'm gonna just talk to myself. Let's see, is that high or low? That's low. Okay, so I know it's acidosis. Look at the next value. Oh, that's high. So high, low. Okay, it's a respiratory cause. Is the other system helping? 25 is in the normal range. It ain't helping. So without renal compensation. Does anyone think they need more practice? No. What I'll do during the lab, because some of you are yes, some of you are no. I'll put 4 more up here, and I'll kind of cover the answers, and after you finish your sheet kidney dissection, if you want to just hang around and talk amongst yourselves and help each other through it. If you understand it, great. You know, be a good person. Stick around. Help people who don't understand, and I'll help too. Yeah.
I also think that you have the video on YouTube from like 8 months ago or something.
Yeah.
That does the same thing, and that for me was really helpful just
Okay.
to go through that. So that's something else.
Yeah.
And it's not a long one. Like it's not like you're gonna be sitting there, you know.
Yeah.
Like it's just
The one I did?
Yeah, you did it.
Oh yeah, I think I did in my office.
Yeah, in your office. Yeah.
Yeah, that's
So
up there too.
helpful, too.
And also what can help is, I put a couple more things here. I posted this one as an announcement. It should be available today. And I posted answers. So just 10 more, just to keep going. So these problems with the answers, look for it on Canvas. Wrapping up here. Remember, you got a couple things on proctorial. One was the digestion histology quiz. Raise your hand if you did that. I haven't checked. Because we've done it already. So I believe I said the due date for tomorrow. The other thing that's coming available today is the lab practical 3 on proctorial. Okay, that's up there. And there's a couple of pictures I wanted to mention that I don't want you to get thrown for a loop because it wasn't clear, because it's not clear. There's a couple things that aren't clear on here. Make sure you get. Here's one picture. Have you been studying it? Right, well, test you tomorrow. Okay, well anyways, I think the thing that could be confusing, I taught that the pulmonary artery is on the airway. Right there, pulmonary artery. What kind of blood does it carry? Pulmonary artery. Deoxygenated. But don't let the color fool you. They color it like it's oxygenated, but it's not. That's pulmonary artery carrying deoxygenated blood. The pulmonary vein is off the airway and it carries oxygenated blood. But look at the color. It doesn't indicate that. So don't let the color fool you. Pulmonary vein, and what's this class?
Pulmonary artery.
On the airway, very good. Let's go with that. That's what we're going with for this test. Here's the other model. Talked about this before. The thing that's a little bit nuanced is the difference between bronchial and respiratory bronchial. What do respiratory bronchial have that other bronchials do not? Respiratory. They have alveoli stuck to them. Now this model shows that. You see this bronchial, here's a division, here's another bronchial. Do you see that over there? Ooh. So identify. Respiratory bronchial. What about this one? Bronchial. There's no alveoli on it. It's just a bronchial. If it's a bronchial with the tiny air sacs, it's respiratory bronchial. So I didn't want that to catch you either. Okay, it's a little bit nuanced. So those are the only two things I thought students might accuse me of tricking you. Not trying to trick you. I just showed all my cards. You might get those questions. Okay.